put me in good stead to reach this position. Thank you so much. Thank you, chairpersons. I'll be speaking on promoting healing in IBD, a mucosal perspective. First, let me pay my tribute to Professor Rakesh Tandon, who has been a mentor of mentors. He, after his initial education in India, went to Rhode Island to do a residency and subsequent fellowship. At AIMS, he joined as faculty and continued his work in biliary and pancreatic diseases and did pioneering work in endoscopy and subsequently retired as the head of the Department of Gastroenterology, bringing the department to great heights. He was a great orator on stage, a wonderful friend of stage, and a great mentor. He was an international academic celebrity and a very great collaborator. He won several awards and several hearts, and he was a family man at heart. In his own words, a mentor is one who's a role model, who's accessible to his students, gives time, promotes their careers, helps in networking, and provides guidance. He was all rolled into one. IBD, we will be discussing on mucosal perspective to improve mucosal healing. And as you know, it is a dysregulated immune response in a genetically susceptible host to intestinal microbes, resulting in chronic mucosal inflammation. In a germ-free mice, there is no IBD. Incidence of IBD is rising in India. Understanding the pathogenesis will create therapeutic options, and pathogenesis-directed therapy is likely to improve mucosal healing. There are several guardians for mucosal health: the gut motility, the microbiota, the mucus layer, the epithelial tight junctions, the immune cells, and the perfusion of the gut. Breakdown of these several barriers results in IBD, and the microbiota gain access to the immune cells, setting up chronic inflammation. IBD is a multifactorial disease and hence needs a multi-pronged attack. We made certain observations and tried to raise several research questions, which we tried to answer. Firstly, we felt that Indian IBD patients are living in a contaminated environment, and we wanted to study the role of infections in exacerbation. There is gut dysbiosis which in IBD, which has been studied using fecal microbiome. We studied the role of mucosa-associated microbiome and microbiome in mucosal inflammation. Vitamin D affects gut immunity and gut barrier, and we studied the effect of prevalence of vitamin D deficiency in IBD in sun-rich India and the effect of supplementation. Leaky gut barrier has an important role in pathogenesis. We tried to assess simple tools to assess gut permeability. We know that Indians have a poor nutritional status. We tried to study the role of micronutrient deficiency and its effect on quality of life. A lot of patients had poor compliance due to cost, and we tried to see if turmeric could help. Looking at microbes in the pathogens of IBD, you have the good, bad, and the ugly bacteria. When the bacteria gain access to the inflammatory cells in the mucosa, it sets up chronic inflammation. Dr. Harshudawar did a study, and he showed that the causes of exacerbation, 32% of our patients had infection as a cause of exacerbation. And the infection was detected in the form of stool bacterial culture, CMV in the tissue, and amoebic infection. Infections were more often in patients with IBD than IBS. When I was in Canada, we studied the role of mucosa-associated microbiota and intestinal barrier function in colonic Crohn's disease. And here we showed that the bacteria in inflamed area are encroaching onto the epithelial cells, whereas in those without inflammation, there is a barrier of mucus lining which keeps them separated out. And this data was significant. We also found that patients who had inflamed areas had different kind of microbiota compared to the non-inflamed areas. And we found that there was more pathogenic bacteria in inflamed area compared to the control population. Then we went on to study the role of fungal dysbiosis in IBD. And we found in a study by Dr. Jamil, we found that patients with ulcerative colitis were compared with irritable bowel syndrome. And during endoscopy, we took cytology brushes, we took brush for culture as well as biopsy for culture for Candida and compared it with histopathology. We found that candidal positivity in the stool was in the form of confluent candidal growth, and we also found in the cytology specimens candida, which is shown here as budding yeast cells and pseudohyphae. Candida was more often isolated in stool culture, brush cytology, brush cultures, and biopsy cultures in patients with ulcerative colitis in contrast to controls. The beta-D glucan levels were significantly higher in the serum in ulcerative colitis compared to controls, suggestive that it is invasion by Candida and not just colonization. The Candidal species were predominantly albicans and tropicalis. However, in the control population, there was very little of non-albican species. They were predominantly only in the IBD patients. When we saw patients with severe disease, they more often had confluent growth of Candida in the stool, and those with confluent growth had higher beta-D glucan levels. Biopsy culture positivity for Candida was associated with higher clinical activity as well as histological activity of the disease. And this is published in the Journal of Digestive Disease Sciences. Pilot study as a part of this was done with using fluconazole in 7 patients with Candida, and we found very promising results by fluconazole reducing all forms of disease activity. So we embarked on a double-blind randomized placebo-controlled trial using oral fluconazole therapy to reduce disease activity in IBD. This was done by Dr. Anurag Jaina. And we found that out of 242 patients, 68 were culture positive in the stool, and they were randomized to receive fluconazole or placebo. We found that presence of disease activity and any steroid exposure were independent predictors for presence of Candida in the stool. And on fluconazole therapy, there was significant reduction in the Mayo score in the drug group compared to the placebo group. However, the 3-point fall in Mayo score, though was numerically higher in the drug group, was not significant compared to the placebo group. There was significant improvement in the calprotectin, which dropped from 375 to 87. However, there was no significant drop in the placebo group. Histological activity score also showed significant drop in the drug group compared to the placebo group. When we looked at the histology, there was a lot of inflammation pre-treatment, which improved significantly after treatment. This was published in the Journal of Clinical Gastroenterology. Then we went on to move to look at the role of vitamin D in IBD. And we found that vitamin D has a significant role in acting at all the components of pathogenesis of IBD. So we hypothesized that it should improve IBD. And we found that despite India being sun-rich, Indian patients have significantly lower vitamin D level than their age and gender matched counterparts. We also found that longer disease duration, severe colitis, and pancolitis, all of them are associated with lower vitamin D levels. Oral nanovitamin D supplementation was studied to see whether it reduces the disease activity in ulcerative colitis. And this was published in Journal of Clinical Gastroenterology by Dr. Rizwan. And we found that in those who received vitamin D, there was a significant reduction in UCDAI by 3 points at end of therapy. With improvement in vitamin D level, there was a significant reduction in the UCDAI scores and the histology scores. And we also found that it reduced the CRP levels and the calprotectin levels. We interestingly found that those who reached a target vitamin D level of 40 had significant reduction in their UCDI scores. And since then, we have been using 40 nanograms per ml as target. Apart from vitamin D, there are other micronutrient deficiencies also, which are very common in patients with IBD. Anurag Sachan is working on this, and he has found that vitamin D insufficiency is a predictor of poor SIBDQ scores, suggesting poor quality of life. So in order to improve quality of life of these patients, we have to do two things: correct vitamin D level and induce histological remission. Intestinal barrier is leaky in patients with IBD. It is difficult to study. It perpetuates inflammation. So we studied confocal laser endomicroscopy when I was in Canada, where we gave fluorescein, and you can see these crypts, which are very well lined and highlighted. And you can see the vasculature around the crypts, and the crypt lumen is slit-like and dark. Here we can see that there is evidence of excess vascularity, as well as the crypts are distorted, and you can see that the crypt lumen is now widened with leakage of fluorescein, and we can see that there is increased vascular permeability. When we looked at these areas on Ising chamber, we found that there was increased paracellular permeability and also excessive fluorescein leakage. We can use various sugars to test permeability, but it requires HPLC and a dedicated person like Pooja who did the study for us. And we found that there's increased gastric and intestinal and whole gut permeability in IBD. However, to make it simple, we gave oral iohexol and collected the urine over 24 hours and stacked the urine after centrifugation, put it into a CT gantry, and studied the Hounsfield unit, which was proportionate to the iohexol levels in the urine. And we found that those with severe disease more often had higher urine iohexol levels. This was done by Dr. Arun Veerabhadra. And we also studied the role of oral turmeric powder in disease activity in UC, a double-blind randomized controlled trial conducted by Dr. Shiva. And we hypothesized that turmeric is easily available for our patients to have, and it puts health back into their hands. It has antibacterial, anti-inflammatory, and anti-cancer property. So we gave 5 grams of organic cold pulverized turmeric to these patients, and we showed decrease in calprotectin and decrease in UCDI scores and high patient acceptability. Also, we have to shift our goalpost from symptom improvement to mucosal healing, for which we need biomarkers, better tool for endoscopic assessment, and validated histological scores. So to assess endoscopically, we used NBI scoring system, and we found that NBI scoring correlated very well with the endoscopic scores and disease severity. And for histological assessment, we used the Robert Histological Index, which is a validated score. And we found that it had a better relationship with the Mayo endoscopic score. And we also realized that even when endoscopy is normal, it is important to do a biopsy to establish mucosal healing. Various biomarkers were studied. We found role of fecal myeloperoxidase was useful as a biomarker in the activity and severity of the disease. Dr. Ibrahim did this study. And then we found that fecal lactoferrin and myeloperoxidase reduced with treatment, and hence can be used as monitoring tools. So in conclusion, mucosa-associated microbiome is different in patients with IBD and is more useful to study this than fecal microbiome. There is associated bacterial dysbiosis in patients with inflammation. There's also fungal dysbiosis with excess of candida. Treatment with fluconazole was found to be useful. Mucosal permeability is increased and can be studied by various methods, and it is related to disease activity. Micronutrient deficiency is very common. Vitamin D deficiency especially is very common, and we should treat that, and it helps in reducing disease activity. A target vitamin D of 40 nanograms per deciliter improves disease activity. Mucosal healing is required to be the target, for which we have to ensure compliance and use objective assessment tools. Translating into clinical care, we have set up an IBD clinic and kept mucosal healing as a target, use biomarkers for monitoring. We test, treat, and target strategy for vitamin D, and provide personalized counseling for disease, diet, and drugs. There's obviously teamwork at PGI. We have a huge IBD team consisting of all our faculty and collaborators, all our DM students, and our research scholars. Thank you.
Dr. Datta wanted to play a video. Ma'am, are you playing a video?
No, I'm not playing a video. I just wanted to come on
Yeah,
live. Thank you.
okay.
I'm indeed grateful to ISG for having conferred this award, and it is the best way as a mentee I can pay my tributes to my mentor. Thank you so much.
Thank you, Dr. Datta, for a very brilliant oration. It's a fitting tribute to Dr. Rakesh Tandon, as all of us know that he was such a giant in our field and he guided this society through many highs and lows. And thank you very much for accepting to give this oration. I thank the co-chairs and all of you who have stayed with us during this meeting. Thank you very much. And there will be no questions since this is an oration. If you can put any question in the chat box if you feel. Thank you.
Thank you. Thank you, Chairpersons, Dr. Yogesh Chawla,